Good afternoon. My name is Snezhina Ranovich. I'm psychiatric mental health nurse practitioner at University of Miami. I'm also a family nurse practitioner. Today, I will talk about ethical and legal issues related to mental health. Some of the objectives that I will cover will be describing patients' Bill of Rights in psychiatric practice, explaining TARSO decision and its application in psychiatric mental health, understanding the applicability of habeas corpus in psychiatric mental health. I will also describe capacity versus competence in psych practice, and I will cover informed consent, ethical principles, and legal issues. Why am I talking to you about legal rights and legal issues? Well, psychiatric nurse practitioners, they don't get sued a lot because we are famous for maintaining good relationship with our patients and keeping good documentation. All of this is very important when it comes to malpractice and any type of ethical legal issues. So the first subject that I will cover is Patient's Bill of Rights. Patient Bill of Rights has four components. The first component is right to treatment. So, right to treatment is basically that every individual with mental health, just like individual with any type of physical health condition, has the fundamental right to access timely, evidence-based, and quality care. Mental health conditions have to be treated with the same urgency, just like any physical health conditions. This includes access to appropriate providers, therapeutic interventions, medications when indicated, and continuity of care. Discrimination, stigma, or limited resources should never be barriers to treatment. Second part is right to informed consent. This is the right basically grounded in ethical principle of autonomy and self-determination. Patient must be given clear information about the nature of proposed treatment, risk and benefits, potential side effects, reasonable alternatives, which also include right to no treatment. Consent is not just obtaining signature. This is ongoing conversation between the provider and patient. The patient must have a decision-making capacity and must make the decision voluntary, free from coercion. For example, when initiating an antidepressant with our patients, it is our responsibility to discuss expected timeline for improvement, possible side effects, non-pharmacological options such as psychotherapy, and just make our patients aware of all these options and give them the clear picture. Because to have a true informed concept, we need to have good partnership with our patients. The third part of the Bill of Rights is right to refuse or decline treatment. So every patient has the capacity to make this decision, and this applies to medication, hospitalizations. This applies to hospitalizations in the cases where legal criteria for involuntary treatment are not met, because we, as the psych providers, we do have option to Baker Act our treatments and to Baker Act our patients, sorry. So patients sometimes can decline treatment or medications because of their negative experience in the past. And our role is not to pressure them, but to explore concerns, provide education, and discuss alternatives. Respecting patients' refusal reinforces trust and preserves dignity. Proper capacity assessments and documentations are essential in these situations. And then the last one is right to express their personal beliefs and values. So just like in any type of healthcare, we are taught that culturally competent care, which includes spiritual beliefs of our patients and their cultural beliefs as well. Um, so sometimes in mental health, patients might have some different type of coping mechanisms that are influenced by their culture. So sometimes patients might express emotional distress through physical symptoms. Also, sometimes patients might have religious or cultural perspective on their treatment preferences. So, as a mental health practitioner, we have to provide culturally competent care and keep this cultural humility, self-awareness of bias, and, and have trauma-informed practice. When patient feels respect and understood, adherence improves and therapeutic relationships strengthens. Together, all of these rights emphasize that individuals with mental health conditions are autonomous partners in care. They deserve dignity, respect, and shared decision making. Now we'll talk about types of law. So types of law basically has to do with patient safety and risk in mental health. Patients with mental health may sometimes exhibit behaviors that pose risk to themselves or others. While most individuals with psychiatric conditions are not violent, certain acute conditions such as untreated psychosis, severe mood episodes, or substance use disorder can increase risk in specific situations. These behaviors may jeopardize the safety of patients in an inpatient setting or family members at home or even healthcare professionals that are providing care. As clinicians, we are responsible not only for therapeutic support, but also for maintaining a safe environment. So how did Tarso law come about? So Tarso rule originated from landmark 1976 California Supreme Court case Tarso versus Regents of University of California. So in this case, a graduate student named Prosenjit Podar confided to his therapist at the University of California that he intended to kill this woman named Tatiana Tarsov. So the therapist notified campus police, but he did not warn Tatiana or her family. Podar was briefly detained by police and then released. Tragically, he later killed Tatiana. So her parents sued the university, arguing the therapist had the duty to warn their daughter. California Supreme Court ultimately ruled that the mental health providers have a duty to warn or duty to protect identifiable third parties when a patient makes credible threat of serious harm. The court stated that protective privilege of confidentiality ends where the public peril begins. So, how does this apply to psych practice? Well, the Tarsoff rule applies specifically when a patient makes a credible threat, a threat is serious, and the potential victim is identifiable. In those cases, the clinician has duty to take reasonable steps and protect the intended victim. So these steps will be warning the potential victim, notifying law enforcement, and initiating involuntary hospitalization. The key principle is that the benefit of preventing harm outweighs the duty to maintain confidentiality. So now you might say, oh, but what about HIPAA? You all know that we as practitioners must follow HIPAA guidelines. Well, we still follow HIPAA as mental health providers, but however, HIPAA does allow disclosure of protected health information when necessary to prevent or lessen a serious and imminent threat to health or safety. So Tarsoff law does not contradict HIPAA. It works within exceptions that permit disclosure for safety purposes. So when clinician acts in the good faith to warn or protect under Tarsoff guidelines, they may be protected from liability related to the breach of confidentiality. Failure to act, however, can result in legal consequences. So ultimately, Tarasov highlights this ethical tension between the confidentiality and public safety. But as a mental health professionals, we must carefully assess dangerousness, document truthfully, and balance patient trust with our duty to protect others. Now we will cover habeas corpus. So habeas corpus is basically um, a process that safeguards. It basically means everybody has rights. Individuals with mental health conditions retain additional legal protection, especially in situations involving involuntary hospitalization or civil commitment. One of the most important protections is the right to due process. Civil commitment is a significant deprivation of liberty, so it must follow strict legal procedures to ensure that the patient's rights are protected. So, what is the due process? Due process means that the patient must be informed of the reason for detention. There must be legal justification for involuntary commitment. The patient has the right to hearing before a judge, and the patient has the right to legal representation. A key legal safeguard in this process is the writ of habeas corpus. Habeas corpus means literally in Latin, you shall have the body. It allows a detained individual or someone acting on their behalf, such as family or a judge, to challenge the legality of their detention in court. This means a patient can directly or through an attorney question whether their hospitalization meets legal criteria. Additionally, family member, friend, or relative can petition as well in the court a writ of habeas corpus on the behalf of the patient. So this is basically to ensure that involuntary commitment is not identified or unjustified, and that the patient's constitutional rights are protected. So the habeas corpus reinforces that even during psychiatric crisis, patients do not lose their fundamental civil liberties. Mental health care must be always balanced safety with respect for individual rights and legal protection. So now we'll talk a little bit about this law. How did this law come about? So this law emerged from English common law back in the 12th and 13th century. This was used to make sure that people were not imprisoned without due process, without judgment. And then in 1215, we have Magna Carta, which provided the foundation for English colonies that came to the America. And then they incorporated this law into Constitution, Article 1, Section 9. So it is basically a safeguard to personal liberty. So now we will move on to patient abandonment. Patient abandonment is let's see, patient abandonment is basically it is when the healthcare practitioner has when they have when the healthcare practitioner has like relationship with a patient, we basically have to make sure that we are they're meeting the legal requirements in order to prevent a civil lawsuit. So patient abandonment is not simply dissatisfaction with care. It is a legal concept that occurs when a healthcare provider terminates the provider-patient relationship. So therefore, we have to keep reasonable notice for our patients if we're gonna terminate this type of relationship. So for the patient abandonment, there has to be a provider-patient relationship. So when the patient comes to see you in psychiatric practice, they always sign a paper that they agree to treatment. So the moment they sign this paper, we have this type of relationship. So without the proof of this relationship, there cannot be no claim of abandonment. The second part is unilateral termination of relationship. So provider cannot end the relationship without reasonable notice. Healthcare providers are allowed to withdraw from care, but they must provide adequate notice, sufficient time for the patient to secure alternative care, referral when appropriate. So abrupt termination without these safeguards may be considered abandonment. And now failure to provide opportunity for continued care is the third part. The patient must show that the provider failed to ensure continuity of care. This is very important in psychiatric practice, where sudden discontinuation of treatment or medication can lead to serious destabilization, relapse, or harm. The providers have an ethical obligation to avoid leaving patients without access to necessary care. And then the last part is harm that can result from abandonment. But this is the most critical part. So in malpractice law, the harm must be demonstrated. Emotional distress alone is not often insufficient unless it results in measurable injury. For example, psychiatric decompensation, hospitalization, self-harm, worsening medical condition. There must be a clear causal connection between the provider's actions and the injuries sustained. So in mental health setting, the abandonment can occur if the provider stops prescribing medication without notice, fails to follow up during active treatment, terminates care without referral, or is not available during a crisis without coverage. Proper documentation, clear communication, and transition to planning are essential in risk reduction. So ultimately, patient abandonment cases emphasize that once we enter into a therapeutic relationship, we assume both ethical and legal responsibilities. Safe transition, clear boundaries, and continuity of care are not only best practice, they're legal protection for both patient and the provider. Now we'll talk about some examples of patient abandonment. There are many different examples. Some of them include failing to contact patient who misses appointments to follow up and schedule further treatment. You're supposed to call your patients and check on them and see like why they're not coming. Like if they're constantly failing to show up, you are allowed to discharge them from care. Also, failing to communicate about urgent medical issues with patients. For example, many of psych patients are often on medications that need to be monitored, such as lithium. If patients' labs are out of range, you need to call them. Also, for mood stabilizers, sometimes they're on medications they're used for seizure, such as Capra, and those medicines you also have to keep an eye on the levels. So communicating these levels to the patients is very important. Another example is scheduling appointments that are so far in the future that the patients are gonna get worse. So the best thing here is to follow the practice guidelines and schedule appointments according to the practice. Also, refusing to continue treatment of a patient without justification. This is another big reason that you need to always justify why you're dismissing the patient for your practice, and you have to document this. Also, healthcare provider becoming unavailable and not providing access to backup or on-call physician. So if you're going on vacation or on FMLA, anything like that, you must have another provider to cover you. So therefore, your patients can be seen. So now, in order to pursue medical malpractice, the patients have to meet all these criteria. There has to be a relationship, as we mentioned. There has to be a contract that you signed or a verbal contract where you entered in care with the patient. Then the second part is the discontinuation of relationship has to be during the critical stage of treatment. And patients are really considered critical when they're still in need of medical attention or are in the process of undergoing a course of care. The third part is the doctor or nurse practitioner must stop treatment abruptly. So the treatment is stopped so abruptly and the patient does not have time to seek alternative source. And then also the last part is the abandonment must cause harm. Any of these cases of malpractice, they have to have some type of actual measurable consequences where patients suffered some type of harm in order to be sued. So although abandonment is a serious issue, there are circumstances where the healthcare providers are allowed to end relationship. So we can stop relationship with our patients if we don't have necessary training of knowledge to continue treatment. If we do not have supplies of or resources for treatment, if there is some type of conflict of interest, or if the patient violates policies of the doctor or the practice, such as if they're verbally abusing the care provider or if they're constantly calling the office. Also, if the patient constantly misses or cancels appointments, that's another reason. And also for patients who do not comply with the care recommendations. So when you have a valid reason to end relationship with a patient, you have to ensure that certain steps are met so you will not be legally responsible. For example, you have to give them a notice. You have to give them the appropriate time, like appropriate window of time to find alternative care. And you have to send patient records to the new physician that they will find. So now, what I will talk about something in Florida. So Florida Board of Medicine has rules for us that we must follow. And basically, for any practitioner in Florida, if you're ending a relationship with your patient, you have to give them 30 days to allow them to find a new practitioner. So Florida Board of Medicine also recommends that the practitioner that terminates relationship should provide assistance in locating another practitioner for the patient. So it is always best to follow your state practice guidelines in order to avoid any type of lawsuit. So to avoid any type of claim, you need to know state laws, as I mentioned, and you have to comply with them, including this time period, which is 30 days. You have to talk about termination with your patient and tell them why or what is the reason. And then you also need to make sure that they have enough medication until they find a new provider. You need to send them a termination letter, which says why they're being terminated and the date, referrals, and record release. The way to send a letter is best by certified mail because then you have a proof that you have sent it. You also have to be available for emergency care for this patient until they find another provider. And if you think there's any type of like lawsuit, it's the best to seek legal or risk management advice. And as always, document, because once it's written, you have a proof. Now I will talk about informed consent. consent. This is legal, ethical, and also administrative parts where for all of us providers. So informed consent is the process by which patient voluntarily agrees to proposed medical treatment or procedure after being fully informed of its potential benefits, risk, alternatives, and consequences. This involves throughout discussion between the healthcare provider and the patient, ensuring that the patient understands the information about their care. This is a fundamental ethical and legal requirement in medical practice, where here we ensure patients' autonomy and protection. Ideally, informed consent needs to follow these elements, has to be voluntary, requires adequate disclosure of information, demands proper material representation, should be appropriately communicated, must be specific to the treatment, and can only be provided by mentally capable and or legally competent person. So what are the key elements to always include for documentation in the informed consent? Their nature of treatment, risks and side effects, expected benefits, alternatives, including no treatment, opportunity for questions, and also patient verbalized understanding and agreed. So, for example, in mental health, I see a lot of patients for ketamine treatment. We do a lot of ketamine infusion for treatments resistant MDD. So the way we document would be the patient was educated about treatment with ketamine for treatment-resistant depression. Potential benefits include rapid improvement in depressive symptoms, risk including dissociation, elevated blood pressure, nausea, and the possibility of temporary perceptual disturbances were discussed. The patient was informed that effects may be temporarily and multiple treatments may be required. Alternative treatments, including medication changes and psychotherapy, were discussed. The patient verbalized understanding and consented to treatment. So now I will cover the timeline of development of informed consent. Basically, it starts from 1905. We have Moore versus Williams. Anna Moore sued for assault after her surgeon operated on the wrong ear without her consent. The Minnesota Supreme Court ruled that the consent was necessary for any surgical procedure. So that's how the whole thing started. Then we also have Pratt versus Davis. Promelia J. Davis sued her surgeon for battery after he performed a hysterectomy without her consent. The court found that he failed to disclose his intentions. Early 1910s, we have Rollator versus Stain. The court ruled against a surgeon who removed a bone during a procedure that the patient had explicitly opposed, extending the principles of established in Moore and Pratt. In 1914, we have Sholanoff versus Society of New York Hospital. Mary Sholanoff was subjected to surgery despite her refusal. George Cardozo affirmed the principle of patient autonomy, stating that adults have the right to determine what happens to their bodies. 1957, Salgo versus Leyland Stanford Jr., University Board of Trustees. So this case introduced the term informed consent. This is where the term starts and it's emphasizing the obligation of physicians to disclose risk associated with medical procedure. Now we'll cover some regulatory developments. In 1981, we have publication of federal regulations for human subjects research protection. And then we also have 1991 adoption of common rule, further defined content. So you all guys know about ARB, which is Institutional Review Board. So anytime you want to do any type of research, you have to apply to ARBs. We have ARB in order to standardize, in order to monitor research that involves human participants, and it's always reviewed by independent ethical committee to ensure safety and ethical conduct. So additional protections for ARB are vulnerable populations such as children, pregnant women and fetus, prisoners, and individuals with impaired mental capacity. We also have this all start. We also have Belmont's report, which is 1979, where we wrote about respect for person, and we have the beneficence and justice, two common themes that came up from this report, and the adoption of common rule in 1991, that is basically a standardized human protection across all federal agencies in the US, rather than having like each agency having different rules. So that kind of keeps everything standardized across the board. Now we'll cover some of influential documents and events. 1964, we have Helsinki by the World Medical Association. 1972, there's a public outcry over Tuskegee study, which led to National Research Service Award Act. And in 1974, establishment of National Commission for Protection of Human Subjects. 1979, publication of Belmont Report, where I just mentioned those principles of justice and beneficence for the patient. So these timelines, they highlight the evolution of patient autonomy and informed consent in legal and regulatory context. Some of the main legal cases that are really important to the psychiatric practice, and they're always tested on the psych boards, are about confidentiality, duty to warn, and patient rights. I already spoke about Tarsoff versus Regent, which is duty to warn identifiable victim. We also have Connor versus Donaldson. This one was in 1975, and basically Donaldson, he was a schizophrenic patient that was that represented no harm, and he was confined for 15 years involuntarily. So he, after his release, he was able to sue, and we came up with this law that says you cannot confine non-dangerous patients. And then in 1971, there's Wyatt versus Stickney, and this case came from prison in I think it was Virginia, because there was a lot of patients that were confined to prison with no treatment, no oversight. And basically, it tells us that all the psychiatric patients have the right to treatment, even if they're in prison. So informed consent is capacity to consent. It reflects an individual's competence in evaluating the choices presented to them. However, this capacity can vary significantly among patients in psychiatric care. For instance, individuals with schizophrenia may be considered competent unless a clinical evaluation clearly determines them unfit to consent. Additionally, a patient's capacity to consent can change over time, particularly if their condition deteriorates. So now we'll talk about capacity versus competence. Basically, competence is a legal term, while capacity is a medical term. That is something that we do as providers. We evaluate our patients for capacity. So that is the big difference. So to define competence, this is a legal term that refers to someone's global decision-making ability, such as in legal proceedings, guardianship, or finances. It is categorical in nature and is determined by the court system, often when there is a dispute about who should make a decision. For example, someone might be described as incompetent to stand trial. However, it is possible for someone to be legally incompetent but still have capacity to make specific decisions, such about their health care. And incapacity is something that refers to patient's ability to make specific medical decision, such as consenting to a treatment. It is a functional term that involves a clinical evaluation by treating physician to determine if a patient understands the nature of and the effects of their action. For example, the patient might have capacity to make a decision that a provider doesn't agree with, but as long as they demonstrate the element of capacity. So decision-making capacity is a critical aspect in patients' ability to make informed decisions about their health care, including the refusal of treatment. It is a clinical judgment made by healthcare professionals, typically physicians or nurse practitioners, based on a comprehensive assessment of the patient's cognitive, emotional, and behavioral functioning. Who can determine capacity? So it's going to be clinician, because we are always with patients. We're always assessing them during each visit. So anyone that has this patient relationship, such as nurse practitioner, psychologist, social worker, therapist. Psychiatrists are more expert in evaluating patients with severe mental illness and may be legally required in some locales to assess patients referred to the courts. However, research comparing their judgment to those of other physicians shows that they're no better at assessing capacity in practice. At some time, however, because psychiatrists perform capacity evaluations frequently, primary care physicians should feel comfortable consulting them in difficult cases. A bioethical panel may also help clarify or delineate the issue that needs to be addressed with a specific patient. So, assessment decision-making capacity. The assessment of decision-making capacity involves evaluating the patient's understanding of the proposed treatment, risk and benefits associated with it, and consequences of refusing or accepting the treatment. The patient's ability to reason through decision-making process is weigh the pros and cons and communicate their choices clearly is also a crucial part of this assessment. Capacity is generally defined by four dimensions or criteria: understanding, appreciation, reasoning, and expression of a choice. So, communicate a choice, understand the relevant information, appreciate the circumstances and consequences, and rationally manipulate the information. So a patient's capacity is usually evident, and physicians can assume that the patient has capacity to make medical decisions if their conversations demonstrate basic logic. So one of the tools that we use in healthcare is mini mental state exam. This is a great exam, and it's a really quick tool that you can use as a provider in any type of medicine, and it will basically show you how well your patient is, like how well their mentation is, and if they score on severe ends of this tool, like you will know that their capacity is not right. And this is like a great tool that you can use for documentation. Now we'll talk about refusal of treatment. Refusal of treatment in psychiatry refers to patients' conscious and voluntary decision to decline recommended medical or psychiatric intervention. This decision is respected part of the patient's autonomy and provided the patient has the decision-making capacity. Decision-making capacity is a critical aspect of patient's ability to make informed decisions. and it includes this refusal to treatment. It involves evaluating the patient's understanding of the proposed treatment, risk and benefits, and the consequences of refusing or accepting. So the patient's ability to reason through decision-making process, weighs the pros and cons, communicate the choices clearly is crucial part of this assessment. And if the patient lacks capacity to understand and appreciate the consequences of decision, this can complicate the refusal process. In these cases, the psychiatrist must weigh the risk and benefits of treatment and consider involuntary treatment if necessary to prevent harm. So, for example, sometimes you have schizophrenic patients that are having severe type of exasperation, and they're not able to reason. They're not able to they're not able to make decisions. And in this type of cases, you have to prevent harm for them. So this is where you really need to assess their capacity, and if they need to be involuntary committed, you need to act. Another good example would be a patient with dementia. Happens in the primary care a lot of times. The patient will come for treatment. You will give them some medicine, and they are not able to make decisions. So here we need to have a proxy, or when we have to, or somebody who's gonna sign legal documents and be like a proxy for this patient to make decisions for them. So ethical principles in psychiatric mental health are basically same as in internal medicine, and they're justice, beneficence, respect for human dignity, life, and veracity. These components are always tested on boards, so I will talk about a few. I will cover them just so you can review this. So the principle of beneficence involves the duty to act in the benefit of other people. So we do not want to cause any type of harm. In the psychiatric mental health nursing practice, the ethical principle of justice involves distributing the available resources equally. So the good example for this would be treating patients in prison equally as patients that are like outpatient. That is justice. Psychiatric nurses can also promote justice by using effective and appropriate treatment therapeutic approaches for the patient. And then respect for the human dignity life requires advanced practice nurses to respect patient rights. So nurse is a provider. Basically, psychiatric patients are guaranteed the same civil rights under the state and federal laws. Legal concerns in psychiatric nursing practice include breach of confidentiality, which would be failing to protect patients' confidential information. So, for example, one of breach of confidentiality can occur. You go to like yoga class, and then you're telling a friend of yours about a patient, but then their mother is a person taking the class with you. Something like that could happen. So you always have to be like very careful about talking about your patients. Also, posting on social media, that's another thing. Sometimes people write, "Oh, what a day. Just finished with a difficult bipolar patient." You can never post things like that because you never know. There might be a friend that referred you a patient, and you might have been seeing that patient at that time. So you have to be very careful as a citizen, as a provider, because all those things like intercept. And also lack of justice, using treatment or therapeutic interventions whose risk or burden supersedes or outweighs the benefits. So a good example for this would be like a lot of times the reps come to your office and they bring you samples. So you should distribute these samples to all your patients, no matter what some patients might be able to afford medicine, some patients might not be, but you should be giving like samples to all your patients that might need it. Thank you for your time and your attention. Now we'll go over some task questions. Which of the following best describes the primary principle established by the Tarso law? A, confidentiality in therapy session must be maintained at all costs. B, therapists have duty to warn potential victims if their patient poses a serious risk of harm. C, patients have the right to refuse treatment under any circumstances. D, therapists are only required to report threats of violence if the patient has a history of violent behavior. So this one, the correct answer is B. We already talked about this because you have to warn the victim. Next question, which of the following scenarios best exemplifies legal patient abandonment that can result in malpractice? A, a physician transfers a patient to another doctor with appropriate notice and without interruption of care. B, a physician goes on vacation and arranges for a qualified colleague to cover their patient during the absence. C, a physician terminates the patient relationship without providing sufficient notice or a referral for continued care, leading to harm for the patient. D, a physician discharges a patient from their care after the patient reportedly refused to follow medical advice. So here the answer is C. And then the last question, which of the following best describes the essential element of informed consent? A, the patient is informed of the risks and benefits of the treatment, but is not given an alternative options. B, the patient is given a detailed medical explanation without the opportunity to ask questions. C, the patient is provided with information about diagnosis, treatment options, risks, benefits, and alternatives, and consents voluntarily after understanding this information. And D, the patient is required to consent to treatment without receiving any information about it. So here the answer is C. These are the references. Thank you for your time and your attention.